Hello, hello, live. Yeah, just a second. Guys, am I audible and is the screen visible? Someone please let me know. Just a second. Okay, that's great. Hey, Pradyut ji. Yeah. Hello, Dr. Haley, Dr. Adebra, Dr. Ravinder, Dr. Anand, Dr. Vishnigam, Dr. Nivedita, Dr. Jasjeet. Thank you, buddy. Thank you. So we'll start. Dr. Vish, Dr. Mahi, 123. Hello, buddy. Hello, 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 hello. So today I'm at Chandigarh. I'm at my house in Chandigarh, and Michelle, Dr. Manoj, hello, buddy. So network is good over here, but not so good. Not so good it is at my Delhi house. So we expect if there is any kind of lag, please do let me know immediately. If there is any kind of lag, please do let me know immediately. And good evening, buddy. Good evening, Dr. Shalini, Dr. Panugarati, Dr. Ravinder, Anshji, Dr. AJ Chaudhary, Salina, Dr. Karthik, Vishnigam. Do you wanted to be the last class, buddy? Hello, Dr. Sparkle. Karthik, do you wanted to be the last class? Thank you, buddy. I'm fine. Don't worry. We won't bother you much. Fine. We won't bother you much. Because most of you have doubt understanding this, so I've added another slide over here. Now, kidneys, as you know from your knowledge of anatomy, hello, Dr. Rahul, Dr. Deepu. We'll try our best to give you the maximum possible there. Fine. So you see, kidneys, they are paired retroperitoneal organ. Paired. That means right kidney, left kidney. Fine. And this is a mnemonic. This is a mnemonic. The mnemonic, you already read that in anatomy classes. What is the mnemonic? The mnemonic is sad puker. Sad puker. Hello, Dr. Jaka Ibrahim, Abhishek ji. Good to see you. Fine. Sad puker. That is the mnemonic. So these are the retroperitoneal organ along with the kidney. For example, the suprarenal glands, fine, the aorta. We're talking about the adrenal gland, inferior vena cava, duodenum, except the first part. So first part is the intraperitoneal part. Remember, first part is the part which is more prone to peptic ulcer, most prone to peptic ulcer. It is the most common part where the perforation will develop, peptic acid perforation will develop, pancreas, except the tail. Now the tail is in relation to spleen, ureters, fine. C, colon, the ascending part and the descending part, fine. Kidneys, paired retroperitoneal organ, esophagus and rectum. So they are extraperitoneal, not exactly retroperitoneal. Thank you, Dr. Green. Thank you, Dr. Green. We're so glad to see you. Abhishek ji, same here. I wish I could see you too. Now, so they are paired retroperitoneal structures, right? Now, I told you that they are extremely vascular, so they receive 15 to 20% of the cardiac output. Fine. So they are just 150 gram in size. Compare this to the liver, fine, which will receive just 10 to 15% of the cardiac output. Fine. So they are paired retroperitoneal organ, very, very small in size. 150 gram in males and around 135 gram in females. 135 gram in females. Fine. So the vertical extent is around 9 to 11 centimeter. 9 to 11 centimeter. Transfer extent is around 5 to 7 centimeter, and the anterior-posterior extent is only around 3 to 5 centimeter. Fine. So they extend just 1 inch above, 1 inch above the iliac crest, 1 inch above the iliac crest. What is this which I was going to show you? Fine. So this exactly is the renal angle. Renal angle. Fine. So they ask you in anatomy, applied anatomy, and in surgery also. So what is renal angle? So renal angle is formed between the 12th rib and outer border of sacrospinalis muscle. Outer border of sacrospinalis muscle. Sacrospinalis muscle. Thank you. Thank you, Dr. Vish. Sacrospinalis muscle. Fine. So this is where all the renal pains are referred. This is where all the renal pains are referred. Fine. So if your patient has any kind of renal pain, this will be referred to in this area. Fine. Now, you see, we've read this in the trauma class probably, and in also the class of liver. What is this? Hepatorenal fossa, also called as Morrison's pouch, space between the liver and the kidney. This is the lowest part in a dependent position, the most dependent part in a horizontal patient. So if there is any kind of bleeding, let's say hemoperitoneum, this all will settle in this area. Fine. Most dependent part in a horizontal patient, most dependent part in a horizontal patient. Now you see, kidney has a true capsule. Kidney has a true capsule which can be easily stretched off. This is not a strong capsule, but the stretching of this capsule gives rise to immense pain, Now, you see, what is the most prominent structure which you can see around the kidney? Most prominent structure which you can see around the kidney is Geroda fascia. Geroda fascia. Fine. Now, Geroda fascia is an extremely strong fascia. Geroda fascia. So, anteriorly, this is called as the fascia of Talt, and posteriorly, this is called the fascia of Zuckerkranz. Fine. This may be important in anatomy, but certainly not important in surgery as far as FMG exam is concerned. Fine. Now, the point I'm trying to convey is that this fascia is so super strong that even if there is a renal cell carcinoma, find such an aggressive cancer, that cancer will take very, very long time to breach this barrier. So what happens is that cancer starts to spread through the renal vein, and then through the inferior vena cava. Ultimately, it can reach the lungs to form cannonball secondaries, and also it can reach the bones. To form pulsatile. Pulsatile means very vascular bone secondaries. Fine. So kidney, which has a strong fascia, posterior the layer of Zuckerkranz, and anteriorly the layer of Talt. Fine. Talt and Zuckerkranz. Fine. Extremely strong. Now, when I told you that kidney is extremely vascular, for example, there is a stone over here and you want to remove the stone. Fine. If you go from here, you will damage this artery. If you go from here, you will damage this artery. So where to go from? This area. Fine. This area is called as the avascular plane of Brodel. Fine. Yes, the avascular plane of Brodel. So this lies on the posterolateral surface of the kidney. Now, about the renal pelvis, what are the relation anterior to posterior? So it is a vein, artery, and the renal pelvis. Now they say, what is applied anatomy in case of renal vein? So renal vein is longer on the left side. That is why left kidney is preferred for renal transplant. Because the renal vein is longer on the left side. Fine. Now the renal artery arises between L1 and L2. What is the significance? 95% of the abdominal aortic aneurysm They arise below this level. They arise below this level. 95% of the, good evening, Dr. Subhashji, they arise below this level. Arise below this level. Fine. Now, similarly, ureters, they also arise at the level of intervertebral disc between L1 and L2 vertebra. L1 and L2 vertebra. Now, what is important when we talk about the anatomy of the ureter? The important thing is the 5 narrowings of the ureter. 5 times when the ureter becomes very, very narrow. First is the origin only, that is at the pelvic ureteric junction. Pelvic ureteric junction. Second, crossing with iliac vessels. Crossing with iliac vessels. Reshu beta, I'll just talk to sir. I'll just talk to sir. Don't worry. Don't worry. Hello, Dr. Shah. I'll just talk to sir. Fine. Then the crossing with vas deferens in males, crossing with broad ligament in females, crossing with broad ligament in females. Fine. Second is, the fourth is entry into the urinary bladder. Entry into the urinary bladder. Second is intramural ureter. Intramural, that means where it is lying between the muscles of the urinary bladder. Lying between the muscles of the urinary bladder. Fine. So you see, this is urinary bladder, this is the ureter. So you must be seeing, naturally, when you will enter into practice, you will see many of the stones, they are stuck up at the vesico-ureteric junction. Vesico-ureteric junction. Fine. Now, we talk about the congenital anomalies and the one-liner there. Most common congenital anomaly is vesico-ureteric reflux. Vesico-ureteric reflux. Most common congenital anomaly of upper urinary tract is duplication of the ureter. Duplication of the ureter. Most common vascular anomaly is supernumerary renal artery. Supernumerary renal artery. That means more than one renal artery. Fine. Now, what is the dromedary hump? You see, the fetal kidney is like this. Fine. Lobulated. So when the child is born, everything becomes smooth. But sometimes one of the lobulation may fail to disappear. That time it is called as dromedary hump. It is perfectly harmless, perfectly normal condition. Dromedary hump. Fine. Now, here you see medulla has gone into the cortex. Sometimes cortex can come into the medulla. Sometimes cortex can come into the medulla. That is called as column of Burton. Column of Burton, as you can see on your screen. Column of Burton. Fine. Column of Burton. Right. So you see, again, you can see here the column of Burton, as if, the cortex has come deep inside the medulla. I'm seeing it on your screen. Probably there's no lag, I believe. Fine. Okay. Now, see, what is this? This is persistent fetal lobulation. Another harmless condition. Retrocaval ureter. Here you see the uterus is normal. So the ureter is normal. Only thing is inferior vena cava, rather than being posterior to the ureter, has actually come to lie in front of the ureter, has come to lie in front of the ureter. So this will give to reverse J appearance, reverse J appearance on the intravenous urography, reverse J appearance on the intravenous urography, reverse J appearance on the intravenous urography. So treatment is ureterostomy. We don't do anything to the inferior vena cava. Rather, we bring the ureter in the front and rejoin it. Fine. Right. Now, we move to the next thing there, that is the horseshoe kidney. Like all the important organs of the body. You see, let's speak about thyroid. Adults, we have it in the neck, but it forms in the tongue, foramen cecum. Then it descends down. Fine. Testes forms in the abdomen, descends down into the scrotum. Similarly, kidneys, they form in around the groin area and then they ascend up. Then they ascend up like this. You can see on your screen. This is how they ascend up. This is how they ascend up. Fine. See here. You can see the kidneys ascending up. The kidneys ascending up. Right. So they form in the groin area and then they ascend up. Then they ascend up separately. Now what happens is horseshoe kidney occurs because of fusion of the kidneys. Because of fusion of the kidneys. Naturally, when the kidneys they are fused, fine, this artery called as inferior mesenteric artery, it will not allow the kidney to ascend up. It will not allow the kidney to ascend up. So they are commonly seen lying around the pelvis, very much low from their normal position, very much low from their normal position. Inferior mesenteric artery halts the ascent of the kidneys, halts the ascent of the kidneys. It will not allow the kidneys to move up. It will not allow the kidneys to move up. Horseshoe kidney. So they appear like this. Fine. Horseshoe kidney. Horseshoe kidney. So it allows due to union of the two poles. So most commonly it occurs at the lower pole. So inferior mesenteric artery, it stops the ascent of kidney. It stops the ascent of the kidneys. Fine. So it is slightly more common in males. Slightly more common in males. So where the kidneys join, that area is called isthmus. So this lies in front of third or fourth lumbar vertebra. Most of the time, the kidneys are asymptomatic. Fine, asymptomatic. Most common complication is nephrolithiasis. Most common complication is nephrolithiasis. Most common presenting clinical feature is vague abdominal pain. Vague abdominal pain is the most common presenting clinical feature. You must be aware about Rovsing sign, not the Rovsing sign which we see in appendicitis. Fine. So that will be pain, abdomen, nausea and vomiting, which your patient feels on hyperextension of the spine, Now, this is what you get to see on intravenous urography. Medialization. See, normally the kidneys would have been like this. Normally they would have been like this. Fine. Very far apart from each other. Very far apart. But what is the situation over here? The situation is like this. Let's say This is the inferior pole. Let's say this is the inferior pole. Now you see inferior pole, how far it is. But here, inferior pole, how close it is. How close it is, inferior pole. Fine. So what do you get to see on intravenous urography is medialization of the calyces. Medialization of the calyces, which gives rise to typical hand joining sign, and also flower vase appearance, of the ureter, flower vase appearance of the ureters. Fine, flower vase appearance of the ureters. See here, the ureters, they are appearing like flower vase appearance of the ureters. Fine, flower vase appearance of the ureters. This is horseshoe kidney when they are seen, horseshoe kidney when they are seen on CT scan, horseshoe kidney when they are seen on CT scan. This is horseshoe kidney when they are seen on scintigraphy, the nuclear scan. Horseshoe kidney when they are seen on MRI. Fine. Now you see the stone formation in the horseshoe kidney. Stone formation in the horseshoe kidney. Right. So the only thing which they ask is that the kidneys, they should not be separated from each other. Only thing when we cut the isthmus is when we want to approach the abdominal aorta. If there is any problem with the aorta and we want to repair it surgically, only then we will cut the isthmus. Otherwise, we will not cut it. Fine. Next, we move to the next topic, polycystic kidney disease. What is polycystic kidney disease? So what kind of disorder it is? Autosomal dominant. Genetic defect lies in the chromosome number 4 and chromosome number 16, usually bilateral. Presents in adults. 30 to 40 years is the most common age. 30 to 40 years is the most common age. Cysts, they are present in other organs also. Most commonly, it is the liver where the cysts are present. So brain, it might have aneurysm. Fine. Aneurysm in the circle of Willis. Fine. Now you see here, I'm drawing a renal artery here. See, let's say this is the renal artery and these are the branches of renal artery. So they will reach every part of the kidney, will receive good blood supply, good amount of blood supply, every part. Fine. Now, this is when everything is normal. Now compare this. This renal artery has branches. Let's take just one branch. Now you see here, like this. Every artery will be twisted. Every branch will be twisted. Like this. Every artery and every branch will be twisted. Consequently, what will happen? That this area where I have drawn these black circles or black crosses, fine. These area will receive very less amount of blood supply. Kidneys, they are extremely vascular organ. They cannot tolerate this insult. So what will happen? Renin-angiotensin system will be activated. Kidneys will start feeling that probably patient is entering into shock. Probably patient is having hypovolemia. That is why we are receiving less amount of blood supply. Fine. Fine. So you see here. So there will be renal ischemia affecting some of the part. Renin-angiotensin system will be activated. Aldosterone will be secreted. That is why 75% of the patients, adults, they suffer from hypertension. Now, chronic Persistent hypertension will give rise to ischemic heart disease. That is why most common cause of death in polycystic kidney disease, if the patient dies young, is cardiovascular complications. Fine. If the patient goes on to live up to 60-65 years of age, then the most common cause of death is chronic renal failure. Fine. Because the kidney has developed multiple cysts, so there will be polyuria. Fine. Why? Because the kidneys, they are not able to concentrate urine. They are not able to concentrate urine. Precise cause of this is not exactly known. Precise cause is not yet known, that why they are not able to concentrate. Fine. Also, your patient can experience pain. This pain could be due to infection. This pain could be due to hemorrhage. Fine. Hematuria due to rupture of the blood vessel, rupture of the fine blood vessels. What happens? That because of decreased blood supply, angiogenesis occurs, new blood vessels are formed, and these new blood vessels can easily rupture, which give rise to hematuria. Fine. Now, the investigation of choice here is contrast CT. MRI. Sometimes MRI can be used. It can be used to distinguish simple cyst from the complex cyst. Fine. Simple cyst from the complex cyst. Right. Now, this will give rise to spider leg appearance on the intravenous urography. This is what you were to see on the CT scan. They may occupy large areas. Fine. Berry aneurysm can be important cause of death in young. Fine. Now, what is the treatment? Definitive treatment is renal transplant. Fine. Rovsing operation. That means de-roofing the cyst, just puncturing and removing the liquid. It will just give pain relief. This is not a definitive surgery. Just give pain relief. This is not a definitive surgery. Now, the next topic there, the duplication of the ureters. You can see duplication of the ureter. So generally it is associated with an ectopic ureter. Fine. Now, what you should need to know here is only one thing, that is Bhagat-Mayer rule. Fine. Now you see here, two ureters. Fine. This is the ureter draining upper part of the kidney. This is the ureter draining lower part of the kidney. Now let me draw a midline over here. And let me draw another midline through the ureter. Now, you see here, the upper part of the ureter is draining more medially, more inferiorly, so inferomedial. Fine. Whereas the lower part is draining superolaterally. Let me show you another diagram. There. Fine. This is the only diagram I have. I'm sorry. Fine. So this is where the lower ureter is draining. This is where the upper ureter is draining. Fine. Bhagat-Mayer rule. This is Bhagat-Mayer rule. So upper pole ureter will insert more inferiorly and medially into the bladder. More inferiorly and medially into the bladder. Fine. Now, The next thing, lower pole ureter. Lower pole ureter, as I told you, will insert more superolaterally. More superolaterally. Bhagat-Meyer's rule. Secondly, it may be associated with ectopic ureter. This ectopic ureter will enter into the posterior urethra in males. Fine. Now it will cause recurrent UTI and epididymo-orchitis in prepubertal males. If you get to see this line, epididymo-orchitis in prepubertal males, that means the only diagnosis is ectopic ureter. Ectopic ureter will cause incontinence, continuous dribbling urine in females, continuous. Yeah, fine. So you see here, CMO, superior part, will drain into infero-medial. Fine. Whereas lower pole will drain superior. That is the Bhagat-Meyer rule. That is what they ask in the duplication of the ureter. Fine. Now, it gives rise to drooping lily appearance. Drooping lily appearance. If the upper pole stops functioning, if it stops functioning, that will give rise to drooping lily appearance. Now, ureterocele, there will be dilatation at the lower end of the ureter, dilatation of the lower end of the ureters, as you can see over here. Fine. See, now one thing which I want to take note of this is the opening of the ureter. Opening of the ureter. Can you see how small is the opening of the ureter? How small is the opening of the ureter? So that is why it will cause dilatation of the ureter on the same side. You see it is normal over here. Whereas on the other side, the ureter, as you can see, is dilated. Now, second thing, it will give rise to cobra head appearance. Cobra head appearance, also called as adder head appearance, also called as adder head appearance, adder or cobra, whatever you want to call it, adder head appearance, also called as cobra head appearance, also called as cobra head appearance. Treatment is just to give a nick, over the cyst, and just to give a nick over the cyst. Right? Now, we move to the next thing, that is the topic of stones. Now, by the way, what you can see on your screen, that is the electron microscopic structure of the calcium oxalate stones. Calcium oxalate stones, naturally, they are first grayish white, but because they keep on scraping the inside of the ureter, inside of the kidney, so they accumulate blood. And when they accumulate blood, they become like this. They become like mulberry. Brown colored. Fine. So, urolithiasis, most common type is calcium oxalate stones. They are more common in males because they work outdoor, they sweat a lot, so that is why they pass concentrated urine. Fine. Stones which formed in infected urine, like phosphate stones, they are more common in females because they have a very short urethra. They have more chances of catching urinary tract infection. What are the two theory? The two theory are Carr postulates. The two theories of stone formation are Carr postulate, that means, which says that the stones they form because of blockage of lymphatics. Second theory is Randall plaque theory. It says that one crystal of the urinary salt is deposited. It keeps on enlarging. It says that the crystals of urinary salt, they act as nidus for stone formation. Fine. Now, Most common, as I told you, are calcium oxalate. They are of two types: calcium oxalate monohydrate. Now these stones are very, very hard. Calcium oxalate dihydrate. Fine, these stones are comparatively soft. These stones are comparatively soft. Stones are comparatively soft. Fine. Now they can form at any pH. They can form at any pH. Fine. Now, if they ask you the stones which form in a urine which is acidic, that is normal. Our urine has got normally it is acidic. Fine. What is the mnemonic there? CCU, that means calcium oxalate, cysteine, and uric acid stones. So these are the stones which form in acidic urine, right? Now, the other common causes of stone formation include hyperparathyroidism. Fine. Distal renal tubular acidosis, excess salt in diet will cause increased excretion of sodium. Fine. Now, natriuresis can give rise to hypercalciuria. More of calcium will be excreted. Fine. We'll come to this. Fine. Now you see, this is a calcium oxalate stone, mulberry shape. Initially, it is white. Fine. But then it becomes brown because it has sharp projections. So this will cause bleeding. Because of the bleeding, the stones may turn to brown. Now, the next cause is infection. The next cause of stone formation is infection. Fine. Now, infections sometimes can occur with urea splitting organism, for example Proteus. Fortunately, E. coli, the common pathogen causing urinary tract infection, it does not have urea splitting power. That means it cannot produce urease. What is the problem? Even if the bacteria, they produce urease, the problem is they can give rise to true white stones, that is magnesium ammonium phosphate stones. Sometimes they are also called as triple phosphate stones. Fine. That means calcium, magnesium, and ammonium can be the component. Triple phosphate stones. Fine. Now you see, this is what is done by the urease, which is an enzyme produced by the bacteria. Our urine has got urea. So urease will break down the urea into ammonia, and carbon dioxide will be released. Fine. Now, water is there in the urine. So this ammonia will react with water to release ammonium ion. Carbon dioxide will react with water to release bicarbonate. So that means the urine will turn alkaline. But what is more problematic is that ammonium will be released. Fine. Now, the problem is that this ammonium will react with phosphate. Now, magnesium ammonium phosphate crystals, they crystallize when the pH of the urine becomes high. Fine. When the pH of the urine becomes high. Vishji, Dr. Vishnigam, you want to ask something? Your queries are welcome. Your queries are always welcome. Now, every time they keep on asking what are the different type of stones which are radiolucent, different type of the stones which are radio opaque. So taxi is the mnemonic. taxi is the mnemonic for radiolucent stone. Triampterine stones. Fine. A for acid, uric acid, xanthine. Fine. Indinavir. So these are the stones which are radiolucent. These are the stones which are radiolucent stones. These are the stones which are radiolucent. Fine. Now we see some of the other stones also. We'll see some of the other stones also. For example, the cystine stones. Fine. Now cystine stones, they are very hard. Cystine stones, they are radio opaque, sorry, cystine stones. They are hard, they are radio opaque, they form due to cystinuria, which is an autosomal recessive disorder. Cystinuria, which is an autosomal recessive disorder. Fine. And the urine will have the smell of rotten eggs. Urine will have the smell of rotten eggs. Why? Because the cystine, it contains large amount of sulfur. Secondly, the color will change from yellow to green on exposure to air. What is the treatment of cystine stones when they are just forming? We can use penicillamine. Fine. Xanthan stones, they occur due to xanthinuria. Fine. So I told you they are radiolucent. Secondly, they are brick red in color. They can be treated by allopurinol. Fine. Triampterine stones, you might be wondering where did this came from. Triampterine. So this is the stone which in your exam you will read that these are the stones which form with the use of potassium sparing diuretics. Fine. Then the indinavir stone, NT. It is a protease inhibitor drug, antiviral drug. Fine. Also, you can experience in your patient silicate stones. So these are the stones which form due to long-term use of antacid. Uric acid stone. What is the important thing? They are the most common radiolucent stones. So they form in acidic urine. Fine. They form in gout. They form in myeloproliferative disorder. For example, let's say Burkitt lymphoma. Fine. What is the treatment? Because they form in acidic urine, so the best treatment is alkalinization of the urine, and naturally you can use allopurinol. Fine. Now we talk about the clinical features. So naturally, because they can cause irritation of the urogenital tract, so they will cause pain. They will cause severe pain. Fine. Because they can block the ureter, they can cause hydronephrosis. Fine. Now this pain will occur due to stretching of the renal capsule. So stones, if they are present in upper one third of the ureter, the pain can radiate to thigh by obturator nerve. I'm talking about this pain, and now talking about this pain. Now the first pain was due to kidney stretching of the renal capsule. This pain will present in the renal angle. Ureter pain, if the stones are present here, and here. So this we have discussed that this will be carried down through the obturator nerve. Now the pain here, this might mimic appendicitis. Fine. So this pain can travel through ilio-hypogastric nerve. Ilio-hypogastric nerve. If there are stones present in the lower third, pain can radiate to perineum. Now this sensation might be carried by the ilioinguinal nerve. Ilioinguinal nerve. Also, your patient can have strangury. Patient wants to pass urine, but only thing which he can pass is only 2-3 drops of kidney, only 2-3 drops of urine. I'm really sorry. Fine, only 2-3 drop of urine your patient can pass. That is called as strangury. Painful micturition. Investigation of choice for all the renal stones is non-contrast CT. Non-contrast CT. If you get the X-ray done, 90% are radio opaque, and they will be seen in the front of second lumbar vertebra. What are the differential diagnosis? Calcified lymph node, an ectopic gallstone. Remember, 10% of the gallstones are radio opaque. So calcified tip of 12th rib. If there is too much of calcification, fine, then that can also be seen. And this may also mimic like a stone. Fine. Ultrasound will show hydronephrosis. Now we may also perform intravenous urography. Intravenous urography can also tell us about the renal function. Fine. We can also perform DTPA scan. Now, DTPA scan is now considered the investigation of choice for pelvic-ureteric obstruction. Pelvic-ureteric junction obstruction. Fine. Now, stones which are less than 9 mm in size can be managed conservatively. Just for your practical experience, you can give your patient tamsulosin. Ureter will be dilated. Ask your patient to have plenty of water. Stones will pass. Fine. The surgical treatment of choice these days is considered as extracorporeal shockwave lithotripsy. Extracorporeal means outside the body. So we pass shock waves from outside the body. This is how we pass the rays. This is how we pass the shock waves. And what will happen? These shock waves, they will break down the stone into small fragments. Fine. You see here, your patient will lie. The shock waves will go inside and they will break the stone. Ultimately, when the stone particles become small in size, they can be excreted through the ureter. Remember, I told you that less than 9 mm stones can pass through the ureter. Fine. So if you have a big stone over here, what will the ESWL do? It will just break these stones into smaller fragments so that they can pass. You see here, you can see this image. Dr. Ayat, with appendicitis, your patient will have typical, I told you in the last class that your patient will typically have pointing sign. Fine. Your patient will have nausea, vomiting. Fine. Your patient Rovsing sign will be positive. Fine. In this, your patient will present with more of the urinary feature. Burning micturition will be there. Fine. Usually the fever is not there. Fine. So that's how you can easily differentiate. If you're still not able to differentiate, what is the best thing to get done? Urine routine microscopic examination. That will show hematuria in ureteric calculi. Fine. Well, it may be normal in appendicitis. Fine. Only thing is rarely, if your patient has, let's say, pelvic appendicitis. Fine. In that case, it might become difficult. Then you might have to go in for CT scan. Fine. Now see, this is what we do. Small of the pieces, they pass through the urinary tract. Now, what do they ask is, what are the absolute contraindication? pregnancy. Fine. Uncorrected bleeding disorder, uncorrected distal obstruction. Fine. Next, your patient may have, I mean, these are the absolute contraindication. Your patient may be suffering from urinary tract infection. Your patient may be suffering from generalized sepsis. Your patient may be suffering from chronic renal failure. Fine. Morbid obesity, severe kyphoscoliosis. You may not be able to position your patient properly. Fine. Now, these stones, HCBC, another mnemonic, HCBC. What is that? Hydroxyapatite, cystine stones, bruchite stones. Remember, Sakat Londa, calcium oxalate, mono. Sakat Londa is always single. Calcium oxalate monohydrate. So these stones, they are extremely hard. They cannot be broken down. Most common complication is pain. Next, your patient can also develop Steenstrasse. What is the Steenstrasse? Steenstrasse is also known as stone street. So if there is a distal obstruction, you can see the stones, they will patiently wait in one line to pass out. Steenstrasse, that is stone street. Fine. Stone street. Now, the lower ureteric stones can be removed by ureteroscopy also. Fine. Can be removed by ureteroscopy. Like this. Now, this surgery, percutaneous nephrolithotomy. So that is done if the stone is more than 2.5 centimeter in size. Fine. If the stone is very, very hard, I mean, those stones which we cannot remove by ESWL, we will treat them by PCNS, percutaneous nephrolithotripsy. So first we'll pass a small tube. Over that we'll pass a thicker tube. We'll keep on passing thicker tube until we are in a position to remove the stone comfortably. We'll keep on passing over this. Suppose over this gray tube, we'll pass another thicker tube. Fine, that is percutaneous nephrolithotripsy. PCNL. Percutaneous nephrolithotripsy. So most common complication here is bleeding. Most common organ to get injured is pleura. Also, colon and spleen can be injured. Anugati, but see here, I mean, let's say what you did was you broke the stones into small fragments. You expected that stones will immediately pass. Into the urinary bladder, and then they will be easily passed to the outside. But you did not notice that there was an obstruction over here. There was a big stone which was lying at the uretrovesical junction. So even if you break the big stone into small segments, until or unless you don't remove this stone, rest of the stones will not be able to pass into the urinary bladder. So they keep on waiting in the ureter to be passed into the urinary bladder finally. Fine. That is called as Steenstrasse. Right? Stone street. Now, these are the open procedure. You can open the ureter surgically. You can open the renal pelvis. You can open the kidney substance also. That is called as nephrolithotomy. Fine. So you see, If you give incision over here in the renal pelvis, that will be pylolithotomy. If you give incision here in the renal substance, that will be nephrolithotomy. That will be nephrolithotomy. Fine. Now we move to the benign tumor, and the first tumor which we are going to study is, first tumor is Angiomyolipoma is slightly more common in females. You see, it is composed of blood vessels, muscle tissue, and the fat tissue. Blood vessel, muscle tissue, and the fat tissue. More common age is around 50 to 60 year. I told you already, it is more common in females. Usually it is single and unilateral. Unfortunately, sometimes the tumor can be associated with tuberous sclerosis. Now the tumor will become very aggressive. Tumor will be present more common in young. Tumor will be more commonly bilateral. Fine. So it will be associated with shagreen patches. Fine. What else do you expect? Revise your pathology. Adenoma sebacum. Fine. And ash leaf macule. What is the tumor marker if the tumor turns malignant? HMB45 is the tumor marker. Fine. Now, sometimes it may present with Wunderlich syndrome. That means bleeding in the retroperitoneum. Investigation of choice is contrast CT. Treatment is nephron sparing surgery. That means we don't cut the entire kidney. Let's say if this is the part which has got tumor, fine. So we'll cut just this part. That is called as nephron sparing surgery. Fine. Renal cell carcinoma, many different names. For example, they call it Gravit's tumor. They named it after the pioneering scientist which did research on the renal cell carcinoma. It is called as clear cell tumor because that is the most common pathological variant. Fine. Now, it is called as hypernephroma because it usually arises from upper port. It is called as Internist tumor. Because it is associated with several paraneoplastic syndromes. So it is more common in men. Heavy metal poisoning because occupational exposure. Cigarette smoking. It is common with thorough trust exposure. Remember the one which was also causing hepato cellular carcinoma. It is common in obese. Fine. Now, I told you the tumor may spread through inferior vena cava. That means it prefers to spread by blood. It may also spread to hilar lymph node, and also the lymph nodes around the aorta, aortic lymph node. Most common clinical feature is painless hematuria. Fine. What is the triad? Though it is seen very rarely. What is the triad? That is pain. Sometimes maybe because the tumor may become very, very big. So it may start causing pain. It may start causing pain. Fine. Hematuria. Why will it cause pain? Because of stretching of the renal capsule. So this triad is seen in only 10% of the patient, and only when the disease is very, very advanced. Most common paraneoplastic syndrome is raised ESR. Fine. It is associated with Stoffer syndrome. That means whenever there is renal cell carcinoma, the liver function may deteriorate. Liver function may deteriorate. Fine. Investigation of choice is contrast CT. Contrast CT. Biopsy is not done because the tumor is very, very vascular. So it is only done if there is recurrence, if there is metastasis. If there is metastasis. Fine. Now, we may also do MR angiography because the tumor is extremely vascular. Tumor is extremely vascular, right? Now, what is the treatment? Predominantly, the treatment is surgery because the tumor is comparatively chemo-resistant and tumor is comparatively radio-resistant. Tumor is comparatively chemo and radio-resistant. So, what all do we cut? In the radical nephrectomy, we will cut the kidney. We'll cut the upper two-third of the ureter, upper two-third of the ureter. We will cut the suprarenal glands. We will cut the suprarenal glands. We'll cut the lymph node from the hilum and para-aortic region, also from the hilum of the kidney and also the para-aortic region. Fine. Now, if your patient has bilateral disease, if your patient has bilateral, oh, my brother was calling, that breaks the flow. If your patient has bilateral disease, if your patient has hydronephrosis, if your patient has stones in the other kidney, fine. So in that case, what will happen? In that case, we perform nephron sparing surgery. Nephron sparing surgery. So nephron sparing surgery is also done if the tumor size is less than 4 centimeter. Nephron sparing surgery, that means we will not cut entire kidney. Fine. So if it is done if the stone is less than 4 centimeter in size. Fine. If there is a small tumor which is located at one of the poles, small tumor located at one of the poles. So even though I told you that it is a chemo-resistant tumor, even then sunitinib and cistinib can be used. So drugs like cistinib, what do? They decrease the vascularity of the tumor. So that means they will at least stop the growth of the tumor. They will stop the growth of the tumor. We can do cryoablation. That means we'll do rapid freezing of the tumor. That will practically kill the tumor. Fine. Now, just a second. You see this tumor extending into the renal vein, tumor extending into the inferior vena cava is not a contraindication for surgery. Now, sometimes what may happen is that, let's say this is the renal vein. You see that the gonadal vein, the testicular vein, it enters the left renal vein. Now, sometimes what may happen is that, I'm really sorry for the bad drawing, that the tumor may basically block the flow of blood from the gonadal vein. Now suddenly your patient would sleep comfortably and next day will wake up with a non-reducible left side varicocele, non-reducible left side varicocele, non-reducible left side varicocele. This could be one characteristic dramatic presentation. I'm sorry, one characteristic and dramatic presentation, right? Now, this is also not a contraindication for surgery. The last thing there is Wilms tumor. Last thing there is Wilms tumor. So today also we'll keep it short, and I'm about to finish the class in around 4-5 minutes from now. Fine. So this is considered second most common intra-abdominal malignancy in children. So most common, we consider that neuroblastoma is the most common intra-abdominal malignancy in children. Malignancy in children. You see, which is the most common malignancy otherwise. It is considered to be the acute lymphoblastic leukemia. Fine. Now, this tumor is also unilateral most commonly. This will arise from the upper pole. This will arise from the upper pole. Now, this is associated with with Wiedemann syndrome. This is associated with Wagner syndrome. So Wilms tumor, N-iridia, genitourinary abnormality and mental retardation. Genitourinary abnormality and mental retardation. Denny Drash syndrome. So clinical feature. This will present with a mass. The mass will be smooth. Mass will be firm. Mass will be lobular, and you can palpate it from the front. You can palpate it from the behind, and then you can toss the mass like this. Fine. So that means it will be bi-manually palpable. It will be ballotable. It will be ballotable. Will be ballotable. And this mass does not cross the midline. Does not cross the midline. Investigation of choice. Investigation of choice is contrast CT. Contrast CT. So apart from the treatment, that is nephrectomy, you can do radiotherapy, you can do chemotherapy. Fine. So chemotherapy, you know what is the mnemonic? VCD is the mnemonic. Vincristine, cyclophosphamide, and doxorubicin. Fine. uh I wanted to extend the class, but then today I've got, I'm just here for one day only. I mean, I reached yesterday, but then this was I reached very late. So today I just want to keep the class up to this point only. Fine, I understand that we took at least 1 hour and we could discuss just the kidney. Just the kidney is what we could discuss. Fine, but please do read. If you have any queries, you can always ask your queries. Still, even now, if you have any queries, please do let me know. I'm just waiting for your queries. Otherwise, we are done with the topic of kidney. Rest of the urology we can discuss in some other class. I will keep another class for the rest of the urology. Fine. So I'll request guys there just to. I'm done for today. So can we just